A very good evening to all of you. Myself, Dr. Prateek Garg. So today we will discuss about glomus tumor. Glomus tumor in ENT. So what do you mean by glomus tumor? These are the benign neoplasm arising from the glomus bodies. So look at the slide. This is the most common benign neoplasm of the middle ear. If we talk about what is the most common lesion of the CP angle or cerebellopontine angle, then answer is acoustic neuroma. If we talk what is the most common tumor of the middle ear, the answer is glomus tumor. So usually this glomus tumor mainly arises from either the jugular bulb dome or the promontory. Promontory is the basal cochlear turns impression at the medial wall of the middle ear. So these glomus bodies either may arise from the jugular bulb dome or from the promontory, and these are one of the most common neoplasm of the middle ear. Usually benign, encapsulated, that means a capsule is present around them, and it is a pulsatile tumor. If we do the otoscopic examination of this glomus tumor, what we can see is some pulsatile bulging structure just beneath the tympanic membrane. So glomus tumor are pulsatile tumor which are highly vascular. As the name suggests, they are arising from the glomus bodies around the jugular bulb, which is a vascular structure, or around the promontories. Usually they are present in the 40 to 50 year adult patients, and females are more common. These tumors are locally invasive. We know these are benign tumors, not malignant, so they can't spread very distantly. So what they do is local invasion, causing the conductive hearing loss. Why conductive? Because these are the pathologies of the middle ear. So either they will restrict the tympanic membrane or the ossicular mobility, leading to conductive hearing loss. These glomus tumor are basically paragangliomas, which are arising from the non-chromaffin cells, and we have already discussed these are types are glomus tympanicum, which is arising from the promontory, and it is the most common type, and the other one is glomus jugulae, which is arising from the dome of jugular bulb. Look at the picture of the glomus tumor. You can see this reddish ball-like structures all around. So this is a glomus tumor which is mainly arising from the jugular bulb. As you can see, this blue structure is our jugular vein, and there is a jugular bulb from which this tumor is arising. Now tell me, what is a feeding vessel of this glomus tumor here? So answer can't be jugular bulb. I'm asking about the feeding vessel. That has to be artery. So the answer is ascending pharyngeal artery, which is a branch of external carotid artery. So remember, the main or the most common supply of this glomus tumor in the ear is ascending pharyngeal artery, which is a branch of external carotid artery. And this is how it looks. It is a simplified diagram showing, you can see here, so this tumor is present or going inside the middle ear, as this is our middle ear structure, arising at the level of the hypotympanum, and sometimes it may get enlarged, restricting the mobility of tympanic membrane or ear ossicles. So what are the clinical features? This is an otoscopic picture shown. As you can see, a reddish hue. We can easily appreciate, usually this is pulsatile, so giving an appearance like a pulsations. So we can see a reddish hue arising at the level of the hypotympanum. So what is the clinical feature? The earliest symptom is pulsatile tinnitus. That is the earliest symptom, and particularly in this, the word is pulsatile is important because tinnitus may arise because of the other pathology, but in glomus tumor it is pulsatile, causing the conductive hearing loss. We have already discussed. Tympanic membrane, it will give a rising sun sign, or we can say red reflex, like the sun. If we have seen the rising sun in the morning, we go for the sunrise or sunset, you can see a reddish mass arising from the sea beach or from the hills. So like that, it is a rising sun-like appearance when we do the otoscopic examination. Then there are other signs. One is known as the brown sign or blanching sign. See how the sign can be precipitated or can be measured. If we use the seagull speculum in the ear and if we provide the pressure, because of this pressure, this reddishness will go away for some time. So this pressure by the cecal speculum will lead to blanching of the tumor, which is known as Brown sign or the blanching sign. It is one of the confirmatory tests for the glomus tumor. There is other sign which is known as Aquino sign. So what we do the compression of the ipsilateral carotid artery. We all know this carotid artery branch, that is ascending pharyngeal artery, is giving blood supply to this tumor. So if we compress this ipsilateral carotid artery, again there will be blanching of this tumor. So this is known as Aquino sign. Both these signs have been asked in the past. Okay. And again, this glomus tumor is causing conductive hearing loss. Don't get confused in the examination whether the glomus tumor may produce sensory neural hearing loss. They may produce, but in very late stage. Usually they are presented with a conductive hearing loss. So what are the investigation we do? Firstly, we will do the angiography. So most common feeding vessel is ascending pharyngeal artery, that is a branch of the external carotid artery. And suppose we need to operate over this tumor. So what we can do preferably is the tie-up of this ascending pharyngeal artery. So if we tie up this artery, so there will be limited blood supply and it will be easier to work on this tumor or to operate this tumor because there will be less bleeding. So one of the investigation is angiography, through which we can detect what is the feeding vessel. Then MRI. See, for the glomus tumor, MRI are considered the investigation of choice. And what will they show? They will give the salt and pepper appearance on T1 and T2 weighted sequence. Why salt and pepper? We know salt is white color, pepper is black color. So because in this tumor we can see, try to remember the previous diagram, there are reddish ball-like structure which are the blood-filled spaces, and there will be voidance also. That I mean the spaces which are not having the blood. So because of that on MRI it will give us salt and pepper. That means there are somewhere white dot and then black dot. So that is salt and pepper appearance, which is confirmatory or point diagnostic about this tumor. Then if we do the CT scan, that is contrast enhanced CT scan, so that will give a flap sign. So in CT scan, what we get majorly the bony details. So suppose this tumor is there, so there will be absence of bone between the carotid artery and the jugular bulb. So look out at this diagram. See, this is my internal carotid artery on both the sides. Okay, and this is a shadow representing the jugular bulb. So if this tumor is there, so there will be the bony structure will be absent. Here you can see it is in close proximity, whereas the normal side there is a bony wall or bony separation is present. So this is the flap sign where the absence of bone between the jugular bulb and the internal carotid arteries. So according to Fish, this tumor has been divided into the 4 types. Type 1 is type A, which is confined to the middle ear. That means tumor is limited to the middle ear only. In that case, what we can do, we can go through a transmeatal approach and we can remove the tumor. Then comes the type B. In the type B, the tumor is extending beyond the middle ear, like to the level of the mastoid bone. Okay, so in that case, what we can do, we can either go through the transmeatal approach or external facial research approach, or we can do the cortical mastectomy or canal wall down mastectomy accordingly and can remove the tumor. Then comes the type C, in which the tumor may extend along with middle ear, mastoid, and then it extends to the labyrinth, that is labyrinthine or infralabyrinthine spread. So in that case, what we do by treatment, we use the infratemporal approach and we go through all the labyrinth and clear out all the disease. Type D, which is the maximum spread of the tumor, that is the intracranial extension, which is type D. In that case, what we use is posterior cranial fossa approach. Now, what are the treatment? Firstly, you can do the urine VMA test because these tumors are a type of paragangliomas which are involving the known chromaffin cells. So you can do the urine VMA test to rule out if there is any hormone secreting tumor is there. Then we can do the pre-operative embolization of ascending pharyngeal artery. We have already discussed this is the feeding vessel. So you can embolize this artery before the surgery and then after you can go for the surgery. Surgical excision is treatment of choice for this tumor, has been asked multiple times. So glomus tumor are best treated with the surgical excision. Then in suppose there is unresectable tumor or suppose there is an intracranial extension, then we can opt for the radiotherapy. Okay.